Okay, so thank you for the invitation. You asked me to talk about non-invasive evaluation of coronary artery disease. And the big question that is happening now more and more is, should we do a CT coronary angiogram or do we do ischemia testing? The non-invasive testing has been taking so much space recently with all these imaging modalities. But the CT scan is probably the most important development in the last decade. This technique actually gives us the idea to see what atherosclerosis there is, what it consists of, and how extensive it is. On the other hand, we base still our revascularizations or treatments based on ischemia. So then the question comes, if we talk about non-invasive imaging, should we do a CT or should we do ischemia testing? So I'm going to keep it real simple, this difficult problem. So the first group of people that we have are the asymptomatic individuals or the ones with atypical symptoms. But they have an elevated risk for atherosclerosis / cardiovascular disease. And in this group of people, we see more and more that the question for screening or early detection becomes important. And that's something that we saw coming big time in the US. It's also coming big time now in Europe. The first thing that we still do if we do a CT scan is a calcium score. The calcium score is being done nowadays all with multi-detectors CT scans. When we do these scans, we have a situation like this, where we see no calcifications at all. Here's the aortic valve, here are the coronaries. Or we see some calcifications, or just a very little. So no calcifications, red calcifications, and extensive calcifications. These coronary calcifications gives us a marker for the atherosclerotic disease burden. We're only going to talk about this now, but we realized also over time that a lot of the atherosclerosis that there is not yet calcified. Yet if you do an angiogram, you see it. You see it also to some extent on CT scan. Calcium scoring, that's the simple way of doing it. So the calcium score is the score of how much calcified plaque burden is there. 0 is non-identifiable atherosclerotic plaque. And that's why I put to you, if the calcium score is 0, it does not rule out atherosclerosis, because if you catch the patient at an early phase, there will be no calcification yet, but there will be non-calcified atherosclerosis. A score of 1 to 10 is minimal plaque burden, 11 to 100 is mild. If we go in the direction of 100 to 400, we speak about moderate. And if it's 400 to 1000, we talk about extensive plaque burden. And if it's more than that, it's very significant. These calcium scores have been tested over many years, and you see here 12 years follow-up, all-cause mortality in 25,000 asymptomatic individuals. You could ask yourself your question, is it wise that we test all these asymptomatic individuals? Because almost everybody will have to some extent atherosclerosis. This is the outcome over 12-year follow-up in 0 calcium. And this is the outcome over significant calcium. The calcium score is more than 1000. And there's a big difference between those two. But this outcome here is still 90%. And this is all-cause mortality. So a lot of these people did not die of coronary disease. So you could ask yourself some question how valuable that is. I think it is valuable when a patient presents quickly with chest pain and you want to know, is there something or is there nothing in the heart? This here is then the CT scan as we do it nowadays. CT angiography, the raw data, as you see here, is being taken care of very, very quickly, very fast scanning. If you process these data, you get these three-dimensional views. Here you see the different views of all these. You see the different coronaries. And this is how we like to see them. So this is the post-processing where you get the right coronary. In this case, this right coronary has nothing calcified. Here is a patient with an LAD, and you see that there is some calcifications, but there is also these non-calcified lesions. And this here is the circumflex. We can catch every of these vessels nowadays very, very easily. Here you see an LAD, and here you see a circumflex. One thing that you're going to see the more you use these CT scans is this phenomenon. That is an intramural course of the vessel. That is not atherosclerosis, but it's just running within the muscle. This one is completely normal, except that you see a very little spot of calcium there. This is what we get often. So here is some calcium. Here is mixed lesions. Here is a calcium. Here is non-calcified. Here is non-calcified plus calcified. And here is very diffuse calcified spots and non-calcified lesions. If we take a look at this meta-analysis, which was done already in 2008, 64 slice CT, now everybody uses these 320 CT scanners or even bigger. And you see that if your CT scan is completely normal, the rule out of coronary disease as compared with invasive angiography is very, very good. Normal CT scan is almost completely identical as what you will see on the CT as on the invasive angiogram. So 100% rule out is a good one. So if your question is to your patient, this one is presenting with chest pain and you want to rule out the coronary artery disease, you do a CT scan, it's completely normal, then basically you rule out coronary artery disease. A rule out is good, a rule in makes it more difficult. Now we have these 320 slice scanners and even higher, and they are even more precise than the scans that I just showed you. So now what if my CT scan is not negative, but it's positive? What am I going to do? Am I going to revascularize all of those? And if not, who should I then revascularize and how am I going to manage that? So then the question comes, should we look at the hemodynamic significance of a stenosis? This is the conventional CTA. This is the post-processing into a 3D model. And these are the physiological modeling of the coronary circulation. And then comes the computer calculations of fluid dynamics. And then you can measure the FFR based on your CT scan. And I see here in this vessel an FFR of 0.86, this vessel 0.75, and this vessel 0.95. So we go from pure anatomy to functional consequences. Here we compare some with the CT scan and the angiogram. CT stenosis 70 to 80%. The FFR is 0.94. And you see here the FFR on CT is exactly the same, 0.93. So there is a stenosis, 70 to 90%, but it does not affect your FFR. Let's go a little bit further. We go to a symptomatic patient. This patient has high likelihood to have atherosclerosis, and the question is, does he have ischemia? Do I need an intervention? So then we move away, if that is your question, from a CT scan, an anatomical atherosclerosis assessment, and we go to a non-invasive ischemia test. In the ischemia test, we can do anything that we want. We can do the nuclear test, as you see here. This is the stress situation. This is the resting situation. Here is a perfusion defect at stress. Here it is also. There it is also. If I do now the resting situation, you see that the perfusion defect almost disappears. And then you can quantify the extent of the left ventricle that has ischemia. Oh, goes a bit too fast. We can, instead of a nuclear scan, do a stress echo. We do here in this place a lot of stress echoes if we're looking for ischemia. This is the resting situation. This is the 10 micrograms of the butamine. This is the 40 micrograms of the butamine. You see now significant movement of all the areas. And here's the resting situation. I think the downside is that the echo often not gives you such good visualization. So what we do a lot, here is the patient the same as that one. We give this intravenous contrast. Almost always in every patient where we do stress echo, we do the contrast. So we can much better see the wall motion and the wall thickness. This is what we would like to do in every patient. Here's a resting MRI. here is 10 micrograms, here's 20 micrograms, and here's the maximum. This is, of course, much higher resolution than all the techniques I showed you before. But an MRI takes a lot of time. Some of the patients get claustrophobic in the scan. It's interesting to see here that if you stress this patient with the stressors, the pharmacological stress, you see that the patient develops actually a secondary MR. And then we can measure the perfusion. Of course, this is very great material, but this one here shows you that there is endocardial ischemia, and you measure the perfusion defect here. And then when you do the angiogram, you see 3-vessel extensive disease. So MR functional is dobutamine and looking at contraction. MR perfusion is looking at perfusion and scar tissue. Symptomatic patients, detection of coronary artery disease, when to revascularize. Probably if you have a severe stenosis, or if you have not so severe stenosis, it will be ischemia. Asymptomatic patients at elevated risk, what do we do? Screening. I think we can do a lot of that, but we're also bringing ourselves into difficult situation, as I said. Symptomatic low risk, assess or exclude atherosclerosis. We do a CT scan. In the symptomatic higher risk, here we do immediately ischemia testing. That was all I had to say. Very simple, actually. We work more and more with CT scans, and then we do an ischemia test if we feel that is needed. Sometimes, and that depends completely on the heart team decisions, sometimes we do immediately based on the CT scan, just purely stenosis-driven revascularization. If you look at all the bigger centers, this discussion point of when do we revascularize, do we do stenosis severity or do we do consequences of stenosis, which is ischemia? That question has never been very well answered, and I think that's going to be very difficult. So we stay a little bit in the middle, and we discuss it in the heart team, and based on that, we take our decisions for these patients. Thank you very much.